We're now moving into the final section of our esophageal session, and I'm joined by our expert panelists, Dr. Jock Bergman, Dr. Mimi Cantor, and Dr. Peter Siersema. And want to thank all our attendees for sticking with us. We do have audience response questions, so please take the time to respond to these. And again, this is a fantastic opportunity for you to ask these experts questions that have been burning in your mind with regards to these esophageal diseases that we've talked about. So I'm going to kick off this session by having Dr. Bergman present his teaching video. Jock, do you want to talk to us about your video on management of T1B cancers?
Of course, Sachin, I'm happy to. Let me see if I have control. Okay, so here's a patient, 66 years old, and he has a Barrett's esophagus, and he has this ugly looking lesion, 8 centimeter Barrett's. And the question is, how are we going to resect this? Are you going to use this with are you going to use the Inoue cap to remove this? Is this a case for a multi-band mucosectomy, either with the duet or with the captivator? Do we need to do an endoscopic submucosal dissection, or should we just forget about endoscopic treatment and refer the patient for esophagectomy? So make up your mind. The right answer here is that if you want to resect a lesion like this, there's no way that you can effectively remove this with EMR. Most of early lesions in Barrett's can effectively be removed by multiband mucosectomy and cap-based techniques. But in a bulky lesion like this, you're bound to fail if you try that. So if you would suck in a bulky lesion like this, it would completely fill the cap. You would never be able to cut down to the base of the lesion. You would have an irradical resection, basically be chopping off the head of the lesion and not making an effective endoscopic treatment. So anything that looks bulky or suspicious for submucosal invasion needs an ESD. And here is a video of such a case that we're going to resect with a relatively new knife. This is after we marked and delineated it. And then we're going to do the submucosal injection. There's a variety of fluids that you can use, and there are several commercial fluids that provide you with a more longer lasting lifting. And then it's all about timing and where you do your first resection. And this actually is a nice knife because it has a needle knife to it. So we're opening up the mucosa with the needle. We're looking down on the muscle layer. Here you can see the needle. You can retract the needle, and then you can extend the porcelain ball that actually protects the muscle layer in the deep, and then use the stock of the knife to do the cutting. And by using gravity, and in this case the ball tip of the knife, then you can just cut the hanging part of the lesion in quite an effective way. So we do these under general anesthesia to control the respiratory movements at the level of the cardiac. But usually these procedures take about 45 minutes, and there's no damage to the muscle layer for an effective and safe resection. Now back to the patient. Your pathologist then tells you that this is indeed an early cancer, an ugly cancer. It has deep submucosal invasion. G3 means that it's a poorly differentiated cancer. There's no lymphatic invasion, and your deeper resection margins and your lateral resection margins are free. But the question then comes up, what are you going to do? This is an ugly submucosal cancer, so he needs an esophagectomy, or he actually needs chemoradiotherapy and then an esophagectomy. Or yes, it's an ugly submucosal cancer, but still endoscopic and endosonographic follow-up might be an option. Now, for a long time, we've always said that as long as you're mucosal, you're safe. And as soon as you dive into the submucosa, you're basically in the red. and you need a surgical resection. And that's all because of the estimated lymph node metastasis risk. Now, this lymph node metastasis risk is actually based on surgical series. Surgical series are about 2 decades old. And the problem here is that these surgical series have all cut the specimen in pretty wide intervals. At the time of these series, it didn't really matter if it was a mucosal or a submucosal cancer. The only diagnosis had to be cancer and a radical surgical resection. But if you cut the specimen in intervals like this, you will never assess the deepest invading part of the lesion. So if you find a positive lymph node, you would say in this case that it's a lymph node associated with a SM1 cancer, whereas in fact the deepest part of the lesion is a SM2 cancer. Now, with endoscopic treatment and with our ESD specimens, we do very reliable staging. We cut the specimen in 1 or 2 millimeter intervals, and if there's doubt, we add additional cuts until we really find the deepest part of the invasion. So we're not longer underestimating the invasion depth. And so the current treatment algorithm has shown that as long as you have a submucosal cancer that has low risk, so only very superficial submucosal invasion, and well-differentiated or moderately differentiated cancer, no lymphatic invasion, and a complete resection, the lymph node metastasis risk is probably the same as for mucosal cancers, and endoscopic treatment is justified. But for the high-risk lesions, the one like our patient has, the lymph node metastasis risk is not that what is cited in the literature. It's probably somewhere around, in our analysis, around 16%. And that means that even although this patient has an ugly cancer, he has an over 80% chance of actually already being cured. So the approach that we are using with a number of international centers now is that we do not have these patients undergo surgery, and we wait and see. We do 3-monthly follow-up with gastroscopy and endoscopic ultrasound and a CT at one year. And then we wait for that small subgroup to manifest that lymph node metastasis. And then to treat that with chemoradiotherapy, because those patients then have positive lymph node metastasis and therefore advanced disease. And we simply accept the potential loss for this small subgroup in favor of preventing surgery in most. It's a completely new strategy for esophageal cancer, but it has been around for rectal cancers for quite some time. And it's a trend that you see throughout the GI tract. So the study is aiming to enroll about 140 patients. We have 80 patients in the study now, median follow-up of close to 2 years now, 50 high-risk cancers, so really the ugly ones. And yes, we had a couple of lymph node metastasis patients, but they were all basically cured with surgery. And we had some local recurrences, but again, still managed at a treatable stage, unlike the 2 patients that refused further treatment. So I think in my lecture, I told you all about mucosal cancers and how you should treat them well, because that's an endoscopic area that is already quite accepted. But for submucosal cancers, there's a shift towards potential esophageal preservation. And I think you should speak to the patient and to your surgeon to make a balanced decision and not blindly send any submucosal cancer just for esophagectomy. I'm happy to take any of your questions that you may have in the chat, and looking forward to our discussions.
Chuck, that was a fantastic presentation. I wanted to ask you, and this question is for all our panelists, what's the sort of setup that you have for discussing patients with Barrett's-related neoplasia? Is this done in a multidisciplinary setup? I'm guessing that these patients are reviewed in a multidisciplinary clinic. I'm referring to patients with submucosal cancer before a treatment plan is outlined. And in general, what are your thoughts about the role of multidisciplinary care for patients with Barrett's-related neoplasia?
If I can take a first shot at that. I think, yes, these are cases that we do discuss in our MDT, and our surgeons are on board logically for the protocol that we are using, the study protocol that we are using. But in all fairness, this is basically a discussion between the endoscopist and the pathologist. So what I've realized over the years that me and my endoscopic partners, when we are there, then the oncologist and the radiotherapist basically do not have a lot to add. And the critical questions are usually not asked by the ones that are there. So I think for cases like this, yes, we need an MDT, but we need in our country, we need a national MDT. And I would much rather be pressurized by Peter from Nijmegen, because I think he can ask me a lot of more critical questions as a fellow endoscopist, or maybe his pathologist can question my pathologist if it's really an SM2 or maybe even an SM3, then with all due respect, the input of surgeons and radiotherapists there. So yes, MDT, but maybe horizontal with specialists from different centers and not necessarily with oncologists and radiotherapists in there.
Okay. Peter, Mimi, your thoughts on this?
Yeah, I fully agree with Jacques, of course. I mean, this is really the pathologist who is important in this case. At the same time, if you have a balanced surgeon, of course, he can also be a partner in this discussion. At the same time, also realizing that this is very often not a surgical case, but an endoscopic case that can be followed endoscopically.
Yeah, absolutely agree that I think the pathologist is really key, and sitting with your pathologist first, I believe, as what Jacques said, is so important for you to gain that confidence about what is really a low risk lesion or not before you even brought it into a multi-D discussion. So I agree with everybody.
There's a question from the audience. Jacques, I'll direct it to you first. Excellent lectures. In EUS follow-up of patients who are believed to have been treated endoscopically with T1B cancer, what are you looking at during your EUS? What's your threshold to sample lymph nodes? Are you looking for wall thickness? What are the things that you really focus on during these follow-up EUS exams?
That's a good question. It's very protocolized in our study. The main reason to do the EUS is for the lymph nodes. So basically, I do not look at the esophageal wall, or I do not try to make a diagnosis of a local recurrence in the esophageal wall. For that, I use endoscopy because there's scarring and thickening of the esophageal wall that on EUS you simply cannot distinguish. And any local recurrence that will be there, you will see endoscopically. You don't need EUS for the esophageal recurrence, but you do need EUS for lymph nodes. And then we have a very low threshold of doing fine needle aspiration of these lymph nodes. But very often we find very small lymph nodes, especially in the subcarinal space or in the AP window where you usually find nodes. And then it becomes a little bit cumbersome to needle all of them. Given the rate that we are seeing back these patients every 3 months, it may be justified for some of these lymph nodes that really have a low risk profile, just to simply see if they grow. And we know from series for instance, from Wiesbaden, that the pickup rate is then still adequate, and you will still find these lymph nodes in a curable stage.
Okay, thank you so much, Jacques. Do you also use PET scans in your follow-up at all for these patients?
Well, we do a PET CT at 1 year,
okay,
simply because we don't know. But the cases that we found, we've all picked up either endoscopically for the local recurrence in the esophagus, or we found with EUS clearly a local node that we then needled and then subsequently treated. And actually, then the treatment of these patients it's a different ballgame. We initially envisioned that we would do chemoradiotherapy and then would take out the whole esophagus in these patients. But we had actually 2 patients in which we, in the end, In one patient, we gave definitive chemoradiotherapy. And in the last patient, actually, the only thing we did is remove the node and then continue to follow up, keeping definitive chemoradiotherapy or even surgery still as an option for a recurrence. If there's only a single lymph node that was metastatic, and that patient is doing well for more than 18 months now with a simple lymph node resection. So it opens up a whole new field of how we're going to manage these recurrences.
Yeah, and I think everything that we've talked about really gels beautifully with this whole concept of organ preservation. So I think this was really an important case to make. I know the four of us can talk about Barrett's probably all day, but there was just one more point that I wanted to make to our audience about our response poll question. And I've listed a few statements what could be considered as best practice advice for management of patients with Barrett's-related neoplasia. And our audience was asked which one of the following is not an accurate statement. So the first one really focuses on confirming the diagnosis of any neoplasia by an expert pathology review, treating these patients at expert centers, and these are centers that are really high volume centers with trained endoscopists with access to multidisciplinary care. Endoscopists should be using high definition white light endoscopy and virtual chromoendoscopy, performing EMR followed by ablation of the remaining Barrett segment. And the statement that was not accurate was the ideal candidates for endoscopic eradication therapy. In our statement, we included non-dysplastic Barrett's as well, which is not an indication for endoscopic eradication therapy. Do any of you want to just give some wisdom to our attendees on what constitutes a high quality exam for patients with Barrett's esophagus, apart from the things that we brought up earlier?
I think I could start, Sachin. I think using a CAP is certainly very, very useful, particularly with the ability to do near focus and incorporate, virtual or NBI or any type of virtual digital chromoendoscopy. It really allows you to see better, stabilize, the view. Sometimes there's breathing and contractions and all kinds of things that sometimes make us miss concerning neoplastic lesions. And so I think spend time to examine, use a CAP, and use your digital instrument well, like a camera.
Well, I fully agree with what Mimi says, and I should say also make sure that the esophagus is clean, that you clean the esophagus, and again that you spend enough time visualizing all parts of the Barrett's.
Jacques, do you want to add anything else?
One more thing: retroflex and inspect the lower part of the Barrett segment in the hiatal hernia. This is the area where you will find relatively more lesions and is difficult to see in the antegrade fashion. And please don't take a biopsy until you really have carefully inspected the segment. So look longer, biopsy less.
Perfect. Love that. All right, let's move on to the next case that will be presented by Peter.
Do I present it myself? Because I recorded this as well, but I can also do it.
It's in, I don't know what the production.
Ladies and gentlemen, I'd like to present a patient that presented with tracheoesophageal fistula after chemoradiotherapy for esophageal cancer. This 70-year-old man presented with coughing and choking when eating, and also vomiting and difficulty with breathing. He had undergone definitive chemoradiation therapy for esophageal cancer 6 months ago. Endoscopy was performed, which showed a small benign esophageal stricture and a tracheoesophageal fistula with no endoscopic evidence of malignancy. A stent was placed to seal the fistula. During follow-up, the patient was able to eat, so the patient was happy, but also his treating doctor was happy. The patient returned, however, 12 days later with the same symptoms. And we wondered, of course, what happened to the patient and to the stent. X-ray was performed, which showed no longer stent in the esophagus. So the stent had migrated distally to the GI tract. Endoscopy was again performed, which showed a persisting fistula, and maybe it was even larger than before. It was decided to place again a fully covered self-expanding metal stent and use a clip fixation device to anchor the proximal and distal end of the stent to the wall of the esophagus. And this is the image inside the esophagus. On the right, you see the trachea in the middle of the esophagus, and we performed endoscopy to place a stent and anchor the stent to the wall. Here you see the situation. On the right, you see the trachea. At the bottom, you see left, you see the esophagus, a guide wire, and over the guide wire, a fully covered stent was placed to seal the fistula. Then we noticed that the stent was fully deployed, so we were able to go through the stent inside it and go to the distal part and placed a clip fixation device at the distal part. So the clip was nicely placed over there, fixing the distal part of the stent to the esophagus. And the same was done also at the proximal end, where a clip was placed, sealing the stent to the wall of the esophagus. Here you see the situation, the proximal stent, the proximal clip placed, and here the final result with the stent in place and two clips for fixing the stent to the wall of the esophagus. So here you see this system, this OTSC system. It's a special design for fixing stents to the wall of the esophagus. It's called the Stent Fix OTSC system, and it has the advantage that it has a diameter of only 80 millimeters. And that makes it possible to use it in the esophagus, but also when placing a stent and using it inside the stent, because it is small enough to allow placing this clip at the proximal end of the stent, and sometimes even at the distal end of the stent, to make sure that the stent is no longer migrating. A new device that is now on the market for almost a year, with only limited experience in some centers. So what are the two main take-home messages of this case? In the first place, I think that management of esophageal fistulas, benign perforations or leaks with a fully covered stent is effective, but the risk of stent migration is as high as 35%. And second, there are different methods to fix stents to the wall of the esophagus, and one of them includes the through the scope clips, so-called hemoclips. When they are used, it's preferable to use at least two clips, place them symmetrically opposite each other at the proximal end of the stent. At the same time, we also know that these clips are not firmly fixed to the wall, and very often the stent is still migrating. So these hemoclips are usually not very effective. What is, however, very effective is another device that is the full thickness suturing device made by Overstitch, called the Overstitch made by Apollo Endosurgery, a very effective device, however, not largely available in Europe because of reimbursement issues. And it is also very expensive, so that's another disadvantage of the device. And then there's also the over-the-scope clip, which is cheaper, can easily be placed at least at the proximal end of the Stent Fix OTSC. And I think this is an interesting device that can be considered in cases where you expect migration or already have noticed migration, stent migration, and considering placing a second stent, and when you want to reduce the risk of migration in these patients. So stents can be used for sealing perforations, fistulas, but also leaks. When there is a risk of migration, there are different methods to fix the stent to the wall of the esophagus, one of them being the method I just demonstrated, the over-the-scope clip. Thank you very much for your attention.
Thanks, Peter. I have a couple of questions for you. What's your protocol after you place the stent in? When do you get a contrast study to ensure that the fistula is actually sealed? And the second, I too have now moved away from suturing to the use of over-the-scope clip for prevention of stent migration, but curious to know whether there's a need for fixing the bottom portion and the top, or can we just reserve it to the top? And sorry, and third question, when will you bring the patient back to remove the stent?
Thank you very much. It's three important questions, I think. The first question was, when do you do a swallowing imaging after placing the stent? Well, we usually do this the next day. So we give the stent 24 hours time to expand and to make sure that the stent is fully expanded. And then we make this swallow X-ray to make sure that it is indeed sealing the leak. If you use this stent fix OTSC, then it is usually enough to just seal the upper end of the stent. And usually it's not a good idea to go to the distal part, because there's a risk of migration, of course, going through a stent that's just placed in the esophagus. So I would suggest to only fix the proximal end of the stent to the wall of the esophagus. And the third question was, please remind me.
When will you repeat the endoscopy to remove the stent? How long will it stay in?
Well, that of course all depends on the clinical situation of the patient. Of course, if the area that is sealed is clean, then it can be closed pretty fast, and then you can remove the stent already after 1 or 2 weeks. At the same time, you always have to keep in mind that cleaning the area around the esophagus very often is indicated, and if that's done and it's done carefully and well, then usually, well, these fistulas or these perforations close very fast, and removal of these stents can be done usually within 1 or 2 weeks, as I said already before. Yeah.
Perfect. Thank you, Peter. I wanted to pull up our audience response question, and this really addressed the management of patients with benign and malignant esophageal strictures. And we asked our attendees to identify the statement that's incorrect. And the questions really address the following. One being that wire-guided bougie or balloon dilation is the first step in the management of benign esophageal strictures, which, as you pointed out in your talk, is the appropriate statement. Temporary stenting using fully covered self-expanding metallic stents should really just be reserved for patients with refractory benign esophageal strictures. Esophageal stenting for benign esophageal strictures has a high efficacy rate of 80% with a low recurrence rate. The next option was stenting with fully covered or partially covered self-expanding metallic stents can be considered for palliation of malignant dysphagia with a predicted short life expectancy. So Peter, any comments on the statements that I just made?
Well, the only comment that I have is that the success of using stents for refractory strictures is not as high as you mentioned. It's usually a little bit lower, so it's usually between 40 and 50% at the highest, and there is a risk of recurrent stricture formation after removing the stent. So that is something you have to keep in mind. At the same time, it is possible to place a second stent in patients that have a recurrent stricture formation. So that could be a good idea in these patients.
Perfect. So the incorrect statement was C, and that's the correct answer. We have 10 minutes left, so let's move to Mimi's presentation. Mimi, you're muted.
I figured it out. Yeah, thanks. So this is a very simple case. It's a recurrent GERD in the patient after laparoscopic Nissen fundoplication. This is a real story of a 40-year-old nurse who had acute onset of nausea and heartburn, not relieved by daily PPI. And so obviously we suspected that this might be a recurrence. At age 22, with long time ago, had a Nissen with a paraesophageal hernia repair, which was very successful. And when we evaluated him for these recurrent symptoms, you can see on the left that there's clearly this nice area here which corresponds to the Nissen from the plication, and there was some mild reflux demonstrated on the maneuvers that they generally do. They put them in the supine position, they turn them over, etc. But there is fortunately no paraesophageal hernia recurrence. So this is really key in terms of deciding what to do next in particularly this case. Trying to advance here. Okay, there you go. So here's the endoscopic view. You can see there's bilious fluid in the stomach, and on 4 viewing exam, you can see there's a very, very small hernia here. But the most important part of this assessment is the retroflex view. So many of us do scope patients who've had Nissen fundoplications. And you can see this is, again, when I showed you the clock on my talk, this is the lesser curvature, greater curvature, posterior, anterior wall. And here is the Nissen fundoplication from the inside. You can see that now instead of a 360 wrap, you can see the wrap is now about 180 degrees circumference. And so when you put all that together, you would strongly suspect that this is a particular type of Nissen failure, which really primarily involves only loosening of the wrap versus recurrence of the hernia, which is more common, of course, but this is something that we as endoscopists, as gastroenterologists need to know. This happens probably in about 20%, 25% of patients who have Nissen failures. And Nissen failures, of course, they do happen. It's just a matter of when in some cases. Up to 30% of Nissens can fail over a variable period of time. And so here is a Hill grade 1 anatomy where it's nice and snug around the scope, and you can see the disruption as I mentioned. So of course we do a diagnostic evaluation and we do the manometry is clearly normal. 24-hour pH impedance documents the elevated acid exposure time, and 85% of reflux events were actually in the proximal esophagus, a combination of both acidic and weakly acidic reflux in this patient. And so really important is in someone that you're doing an intervention, I think, is really documenting that this association of symptoms, particularly atypical ones like cough, for example, are associated with reflux if possible, because you don't want to do an intervention that won't make the patient better. And particularly if they have atypical symptom presentation, you really just want to take that extra degree of confidence before you proceed to do some type of intervention. Now, in this case, I have a sort of what would you do kind of slide. You could either double the PPI and add famotidine, kind of do maximum medical therapy, add an antiemetic because he has nausea and maybe even a prokinetic like metoclopramide, send the patient to surgery to repair the hernia and redo the Nissen, which certainly is maybe one of the more conventional approaches. Do a laparoscopic magnetic sphincter augmentation or LINX, which has become very popular among surgeons who have now been turning away from Nissen fundoplications because of the side effects that I talked about. So certainly they would convert this, they would take down the Nissen wrap and then do everything again and replace this with an insertion of this magnetic sphincter augmentation device. And one could also potentially consider a TIF. And I want to talk about briefly is the failure of Nissen fundoplications. Again, this is in the past the most traditional, most commonly performed treatment for refractory GERD. And you can see here, though, that it's just a matter of time for some patients before they fail. And it's particularly true that in young patients who have this operation, they may see a chance of having another operation and even another operation in their lifetime. So in young patients, it's important to really consider, in the future, what the options are. Again, options may increase, but you can see here in a 10-year, between a 7 to 10-year span, about a third of people will fail after Nissen fundoplication. And what we know about this is that the median survival, as even quoted by surgeons, is 10 years for any Nissen. Again, the loosening of the wrap is a minority, but it's something significant to consider. The operative redo Nissen fundoplications are, even surgeons do know that it's difficult. There's fibrosis, it's tedious. You have to spend time dissecting adhesions. And you also increase the risk for injury to the esophagus, stomach, and the vagus nerve. Every time you do a second or even a third redo, and even surgeons will shy away from a second redo surgery, the overall complication rate from Nissen redos is much higher and certainly very, very important to note when you have particularly a young patient again like this, even any patient, but particularly young patients who may have to have it redone again in the future. And the success of the redo is also less compared to the original surgery. It's about 78% compared to greater than 90% in most cases in experienced hands. So again, I want to just show you this very brief case that something we should think about. Again, we were lucky in this case that there was no hiatal hernia recurrence. And in particular, this was the easiest TIF to do. All you do is basically redo the wrap, and this was performed in half the time. And you actually gain back the flap valve very nicely here. And you can see at 6 months, this is the really nice redone valve after TIF, purely endoscopic, ambulatory with a normal Bravo, off PPI, satisfactory, complete resolution of GERD symptoms, and very high satisfaction. So this saved this patient a redo surgery, and this patient is now out at least 3 years and very hopeful that this will last for some time. Certainly, this can be redone if, again, there is no hiatal hernia recurrence. Most recurrences or failures of Nissen, as you know, are from the hernia repair and not so much from the wrap loosening. But it's important to recognize as gastroenterologists that this is something that we can do, that we can help patients with. So I want to just show you the slide that that suggests that there's very minimal data, but at least there's some data. This again is Reginald Bell, who published this in Surgeon Endoscopy. He's a surgeon who would have reoperated these patients normally, but since he does TIF in a fraction of patients who did have this kind of failure, was able to very successfully redo the wrap with just outpatient TIF, and basically showed normalization of the acid exposure, which is what we want in patients who are off PPI. And this again is something that the TIF registry hopefully will demonstrate with future published studies. So I want to just emphasize the learning points of this study, that TIF can certainly be considered as an alternative to a more invasive, riskier reoperation in patients with loose Nissen, but you must have either no or very minimal hiatal hernia recurrence. And so therefore the idea of surgery sparing and these kinds of endoscopic treatments is something that we all need to consider. Thank you.
Thanks, Mimi. That was an excellent presentation. I'm curious to hear from Peter and Jacques whether this whole trend is catching on in Europe or not, this endoscopic management of reflux disease.
Well, at least there are some centers in Southern Europe that are active in doing endoscopic surgery for GERD, but it is not as popular as it seems to be in the US as I think so. And maybe that's not correct. Maybe we should be more enthusiastic about this new possibility. So let's see.
Excellent. And I just wanted to make one more point with regards to our third audience response question. I think Mimi covered it really beautifully in her last slide with her learning objectives. The answer to that question is C, that TIF does not consistently result in normalization of esophageal pH. So with that, I know I have the clock ticking with only 20 seconds left. I want to thank you all for taking the time. Jacques and Peter, I know it's probably around 11 o'clock or later in Amsterdam. So thanks for staying up and being with us, imparting your wisdom on management of esophageal diseases. Mimi, thank you again for being a part of the course, and hope to see you guys in San Diego, and hope you enjoy the weekend. Thanks again.
Take care, guys.
Thank you.
Thanks.